here we are today in our next program, which is actually going to focus on laparoscopic colorectal surgery, but specifically on laparoscopic rectal cancer surgery. And I'm going to try and bring out some of the aspects of the teaching, the training, and delivering the service of laparoscopic rectal cancer surgery. And Bill here is going to introduce our two experts. Bill, over to you.
Well, I'm like the granddad here in the sense that all these three experts have been at some time survived being my registrar, and they've all become key players in minimally invasive surgery and the teaching thereof. So it's a real pleasure to introduce, first of all, Tom Cecil, who has been a lifetime mate, really, because he's still in Basingstoke, and also Mark Coleman from Devon, from Plymouth, who had an absolutely key part, as did Tom, in the LAPCO project, which you'll hear a bit about in a short time. But it's a very proud moment for me to be the granddad amongst these stars.
And I'm like Prince Charles, I'll never be king when Bill is gone. So anyway, if we start with a little bit about the history of laparoscopic colorectal surgery, we'll start with Tom and then over to Mark. Tom, can you tell us when laparoscopic colorectal surgery as an entity began to be delivered?
Well, I think it started to emerge in the 1990s. Early 1990s, there were some people starting to turn the laparoscope to removing bits of the bowel, and there was an early paper by Bill and you, Brendan, with Nick O'Rourke, who was a visiting registrar at the time in Basingstoke, who did a lot of laparoscopic things, and people tried doing cases. It has to be remembered that the equipment was very primitive in those days. We're talking sort of cathode ray TV screens, big boxes, poor visualization, energy devices that weren't really suitable and didn't make it easy. But people did do them, but they took a long time. There were a lot of complications, and I think laparoscopic colorectal surgery got a bad name early on with problems with ports like recurrence and difficulties. And it was largely abandoned, certainly in the UK, where actually there was a ruling made that you couldn't do laparoscopic colorectal surgery for cancer unless it was part of a randomized controlled trial, and that led to classic forming, run from Leeds, Pierre Guillaume, David Jane, and the
What was the classic trial? Just a bit of information, Tom, on the classic.
Classic trial was a trial of laparoscopic versus open colorectal surgery, and it was the only one of the four early trials that did include rectal cancer. And Classic published on its outcomes, and it was controversial, the outcomes of Classic, that the outcomes showed benefit for colon cancer, but for rectal cancer it raised concerns, and the concerns that were raised were a higher rate of margin involvement than in the open group. And the other concern that came out of Classic was that the group who were converted had a 10% chance of dying, of mortality. And that was a concern, that there were probably late conversions where people got themselves into trouble, and operations going on a long time. So those were concerns raised. But there were other trials, the colour trial, the Lacey trial, which were focused on colon cancer and showed a benefit and changed the landscape in the UK, so much that by the early 2000s, this was being explored by a lot of people. There was a lot of people who were keen to do it, but there was no trial anymore to put the patients into. Classic had closed, and so it was a strange time where a few people were trying to do laparoscopic colorectal surgery. There were a lot more people in Europe and the US doing it, but it certainly wasn't commonplace to be happening.
Get Mark's comment on that. So when were you both appointed as consultants?
I was appointed in 2001.
Okay, so you were right at the time when it was sort of nobody knew what to do.
That was almost a pivotal time, because the big trials, Colocost Classic, had reported the early outcome data and showed that many of the early outcomes were equivalent between open and laparoscopic. Classic raised the concern on rectal cancer outcomes, high conversion rate, around 34%, higher but not statistically significant rate of positive margins, which didn't translate into a longer term higher rate of local recurrence or disease-free survival, but nevertheless raised concerns. So 2001, NICE issued guidance to say that this should only be done in the context of a trial. Then, as the decade went forward, people became more interested in laparoscopic colorectal surgery. More data accumulated. Lassie's trial was published in 2003 for colon cancer, but did show a benefit in stage 3 patients in their disease-free survival, but quite a significant improvement in survival, around 30-something%, which is better than any adjuvant therapies ever been proven to enhance survival and local recurrence. So then in 2006, this was the moment, because NICE reissued guidance, and the exact wording was that laparoscopic colorectal surgery should be offered to suitable patients by appropriately trained surgeons. And the law as it stood then was that NICE guidance needed to be brought into practice within 3 months in the NHS. So Professor Sir Mike Richards, who was in charge of the National Cancer Action Team, prompted by some key players, opinion leaders, including Phil Quirke, who's been on this series, to say we need to do something about it and fund a proper training program that prevents the sort of poor outcomes that you saw with the rollout of, say, laparoscopic cholecystectomy in the early 90s, with people teaching themselves, cutting people's bile ducts, high morbidity, and with the whole story about port site metastases in the sort of mid to late 90s, which also in North America, ASCRS, the American Society report stipulated that we should not be doing this procedure until we know more about it.
But the issue about Lacey's trial was very interesting, because the results were so bad in the open surgery. There was a lot of suggestions that Lacey, who's a very good surgeon, if the patient was randomized to laparoscopic surgery, he did it himself, or if it was a randomized open surgery, anybody who happened to be passing by could come and remove the colon. That's probably over exaggerated, but what I'm saying is there is an aspect. That trial was almost too good to be true in one sense, but it did show at least.
And the data wasn't replicating any of the other trials.
No, exactly.
No, and it was.
And it's the problem with trials. In most trials, it's very hard to apply the results of trial to the population. Most of the trials have ever been done, because to get into trial, there is selection and there is skill.
The perfect trial is impossible, really, because the good laparoscopic surgeon is not necessarily the good open surgeon, and you really have to have the same surgeons doing the operation for it to be a truly valid trial.
Well,
that's
not
true. Simply possible. To me, it's crucial with a new method that the people who are best at it show you how well it can be done before you go forward, really. And
that's a good point, and I take your point about the Lassie trial. Or the counterpoint to it, if you like, is that you only required 20 cases to be a laparoscopic surgeon in the classic trial. We now know that's, at the time, with the techniques of learning then, it's just not adequate to say that you're a competent laparoscopic colorectal surgeon.
And what came out clearly of those early trials was that a new technique where people would have been on their learning curve by definition was producing at least equivalent results to open surgery, with significant benefits to the patients in terms of their recovery, blood loss, time in hospital, time to recovery to get back to work and things, so that was what I think changed opinion, which led to the NICE guidance changing, which did create a problem. The UK where really probably only 5% at best of bowel resection has been done laparoscopically.
I think going back to Bill's point, one of the things that you both had, because we tried to train you, whether we were successful or not, you both had an experience in open surgery, and the whole principle of TME, which we've covered in some of the previous sessions, is that actually the operation should be the same, and what laparoscopic surgery brings is less trauma to the patient by having smaller incisions and perhaps better vision and so on. But I think that it's, in one sense, I think most people are now in agreement that laparoscopic colon cancer is undoubtedly, in most cases, the best thing for the patient. There's still some ongoing debate in rectal cancer, isn't there? And whether...
Can I make a point that was very obvious, but people didn't really talk about it at all, and that is that once you start having the surgeon operating on a TV screen, you have the potential to train so many people. And the people the young who have perhaps never seen an open TME should remember that my generation could hardly see into the pelvis as an assistant. A hand went in and there was a loud squelching sound as something came out. But to be perfectly honest, it was very, very crude. And what was coming with laparoscopy was the ability for anybody to see a really good surgeon doing a really good job. That's where the leaders like Joël Leroy and some of the very early stars could inspire the young, who are going to be better at it than us old ones anyway, once they get the bit between their teeth.
You were the only person in the world who took the time and effort, and it was a lot of time and effort, to create good quality videos of open TME.
And I remember mounting the cameras for open.
I remember it well.
Operating
once
like
you've
this.
got a laparoscope, you've got the ability to teach everybody. And you guys have inspired hundreds of people.
There were some interesting challenges though that came out of the early rectal cancer data on laparoscopic, and if you looked at the early series that came up, Mourinho, Joël's series, people producing series of about 100 or so cancers, and what did start to come out was a problem probably with the anastomosis and a higher leak rate in rectal cancer, and the focus came at probably this was in the male pelvis, in fat men, in mid-rectal cancer, where you had to do a stapled anastomosis and there was difficulty with the access, and we were swapping using a linear stapler which closed and filed across the whole rectum in one go to a stapler where we would divide it, taking multiple files across the rectum. And I think perhaps people also thought they didn't have to defunction because of the laparoscopic procedures. And we certainly, Brendan will remember a few cases that he helped me take back to theatre where I thought I could get away without a stoma. And that was a problem, I think.
But you could see that, because conceptually it looks so much neater, tidier, less blood, and you think actually this will be fine. And that was a real challenge in the beginning of laparoscopic surgery. People thought it was actually much less likely to get a leak. In fact, the leak rate is the same.
And the other thing, it was
probably the
taking
same, maybe higher because of the technical aspects.
I mean, the key problem is that we had right angle TA45 type with an open incision. You can get that in, even with a fairly small incision. You can get it in, but you need quite a little bit bigger than just the specimen delivery incision, maybe. But you cannot get a right-angled stapler through even a 1 centimetre, certainly not a ½ centimetre port.
I would just qualify that by saying at the moment.
The whole aspect of teaching, training and the technical things, but I think the whole principle should be the same. And I think, as Thomas alluded to, there are some technical issues which people forgot about or tried to change, and they're an issue. But I think I remember a couple of years ago when we put the reference in, I was put to debate against Robin Kennedy, who is a superb laparoscopic surgeon. He said he could teach anybody, including me, to do laparoscopic surgery. And we were debating about rectal cancer, And what I even at that point in time, I said that it might be better for teaching and training, because you could see, exactly Bill's point, you could see what people were doing. So I think that's really important. We're going to do a section in a minute on the whole LAPCO training and how you train young surgeons.
I think though there's just, it's an interesting story, because it's a story where I think surgeons have been very good at looking at something, addressing the problems and trying to find out the data. And I think people identified that the male pelvis mid-rectal cancer was the challenge, and we've then gone on to have the recent trials that have come out of Australia and the US, where they've looked at this and randomized the male low rectal cancer, and we've gone full circle, because these trials have shown that laparoscopic surgery is probably slightly inferior to open surgery for those patients. And I think and that's led to guidance from our association, which I think is very sensible guidance. It says it doesn't matter how you do it, but do it in the best way you can.
Select the patients properly.
And select the patients properly.
And you're right, Tom, that's a really important.
Just in terms of history, though, it's worth reflecting on the fact that internationally the colorectal community have done a series of well-constructed prospective randomized trials testing the efficacy of the laparoscopic intervention for colonic and rectal cancer, where other specialties, to put it crudely, haven't bothered, and have just used a series of cohort trials or a bit of evidence from here and there to justify, say, doing prostatectomy or other things. And they've struggled to convince hearts and minds that this needs to be done in that way. Yeah. Whereas I think at least we can say we've tried really hard, same with robotics, for example, to prove the concept as we implement it.
I think we'll finish in a minute when we come back to the whole aspect of teaching, training, where you would start, what cases you would start with, and the LAPCO program. But I think that's probably enough for this section. So thank you very much for an interesting discussion. You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.